Good afternoon, everyone. Thank you for attending the work group to study the rise in adverse decisions in the state health plan care system. This is meeting number 4. We are starting today, Thursday, June 11th at 1 o'clock. Thank you all for attending. I just want to welcome everyone. I know we have a lot of meetings scheduled. There's a lot of work to be done, and I just want to thank you all for your attendance and your input. We're going to be talking about the goals and the flow of the meeting, and then some changes in the work group plan. And before we continue with our insurance commissioner, I'd like to welcome Delegate Ken Kerr, who is the House appointment to the work group. So Delegate Kerr, would you like to say hello?
Yes, thank you, Senator Bidel. I've been working in this area now for about 4 years, going back to some legislation we had regarding utilization review, prior authorization, and just look forward to making some progress with this group on this issue going forward. Thank you.
Thank you for your attendance. And now I'm going to introduce our insurance commissioner, which I think everyone knows, but Insurance Commissioner Marie Grant is going to review the finalized draft document of our work group. So Commissioner Grant, welcome.
Thank you so much, Madam Chair. It's great to be here. And thank you everyone for joining this afternoon. We sent out to our members, and we'll have posted on our website very shortly, our updated work plan. We made one little update in the sending, and that is to change the date of a presentation by the Mental Health Association. So just to summarize, we have 3 really important presentations today from MDH and the Medicaid team, from the League of Life and Health Insurers of Maryland, and from our MCO Association. On July 9th, we'll meet again, and we're going to be hearing from the Maryland Community Health Systems Association about FQHCs, and we'll hear from MedChi that day as well. And then July 30th, we're going to hear a presentation from the Mental Health Association of Maryland, and then really get into, again, the discussion and recommendations that we'll be using for our final report. So that's all I had, Madam Chair. I'm happy to answer any questions.
Do any members have questions for the insurance commissioner on the work plan? I don't see any hands. Thank you very much. We do have three presentations today that are going to take a little time, and after each presentation, we'll take questions. So we're going to start out with a presentation by Dr. Dixon, Medical Director of the Maryland Department of Health's Clinical Transformation Unit. So Dr. Dixon, would you like to begin your presentation?
Hi, good afternoon. Thank you. Yes,
Thank you.
I'm not. Thank you. Okay, so I have been invited here today to talk to you about Medicaid's adverse determinations oversight. And next slide. So today we'll spend a little bit of time going over Medicaid and our current reimbursement structure. It's a little bit different for fee-for-service and managed care. I want to talk a little bit about some events that have impacted Medicaid more recently, look at some national and local trends in adverse determinations, give an overview of our regulations and oversight authorities, as well as make some recommendations on next steps and best practices. Next slide. Next slide. So, as you know, Medicaid is split between fee-for-service as well as managed care. So, why is managed care needed for Medicaid? Managed care was launched in 1997 in order to address those rising healthcare costs. Managed care brings the skill set of cost control as well as sustainability for our program. Managed care also applies coordination of care, which we know also saves money for the cost of care through primary and preventive services in order to improve our health outcomes. This was an expanded coverage option. We also expanded healthcare services through CHIP as well as our 1115 waivers. And it builds in an efficiency that aligns with the total cost of care model. As you all are aware, this is the all-payer hospital system model. Next slide. So to compare our reimbursement structure for Medicaid, our fee-for-service program covers members with highly specialized and complex healthcare needs. Fee-for-service is going to be the more expensive reimbursement model because of the complexity of healthcare options under that particular model. We cover specialty behavioral health services under fee for service, our REM program, that rare and expensive care management, the dual eligibles who are both under Medicaid and Medicare, long-term services, those who are physically and intellectually disabled, as well as sorry, I couldn't see. Dental services as and our limited EPSDT services. So that's physical therapy, occupational therapy, and speech therapy for children under the EPSDT program. Our managed care option covers the majority of our Medicaid population. They provide primary care services, preventive screenings, well woman care, family planning and reproductive services, as well as those behavioral health options that are well integrated into primary care. Next slide. So I just want to go over briefly some of the more recent events that impact Medicaid. Next slide. So, as you all know, we were greatly impacted by the pandemic and then the subsequent unwinding. In early 2020, we experienced the global coronavirus pandemic. By March of 2020 to 2023, the federal government provided an enhanced match to many states in order to keep our members enrolled regardless of their eligibility changes. We were experiencing a public health emergency, so it was a priority to keep as many members enrolled as possible. By April 2023 and 2024, Medicaid began redeterminations to unwind that federal continuous coverage requirement. As that funding was changing, Medicaid had to redetermine those who were eligible back to our original categories and criteria. Next slide. What we're facing today is HR 1 and those changes that will target that Affordable Care Act expansion group. So this is going to be the coverage category that will experience the most significant changes under HR 1. That is 22% of the total Medicaid population. Next slide. So this is an infographic that describes what we're facing. Starting in October of 2023, we will roll out that immigrant eligibility changes that will affect about 15,000 members. In January of 2027, the work requirements go into effect. That will also change about 115,000 affected members will undergo some type of change with that work requirement. And then the every 6 months redetermination process is going to begin in July of 2027. That will greatly impact our enrollments on an ongoing basis. Next slide. I want to touch on some of the national trends in adverse determination, just sort of to level set our perspective. So for denials, it is a national as well as a state concern. Denials have been increasing nationally starting in 2016. This particular source reviewed those increases from 2016 to 2020, and we're still seeing that effect across the country. In July 2023, another resource saw that an overall MCOs denied about 1 of every 8 prior authorization requests in 2019. And a similar state in New York, they're seeing higher denial rates from commercial market segments, as well as for Medicaid managed care. Those denials are increasing, and when they're looking at the types of denials, full denials versus a partial denial, there is a little difference. Next slide. So if we're looking at other states with fee for service, Our fee-for-service denial rate is about 12%, which is consistent across the country. In Alabama, they had a denial rate of as high as 34%. South Dakota is pretty low at 6%. Next slide. So for Maryland Medicaid, I'm sure you all are very interested in this part. This slide highlights our inpatient denial dollars. What we saw as we are reviewing the data, MHA did a great job early on in this work group series of highlighting a lot of that data. What we're seeing from the Medicaid perspective is that those total claim dollars are increasing and mirroring that inpatient denial dollars, as well as for outpatient outpatient care as well. We're looking at fiscal year 2023, which showed an increase in denial dollars, and it seemed to be a drastic change that happened between 2022 and 2023, with some stabilization in 2024. The annual volume of denied dollars remained about 42% higher in 2023 and 24 than it did in 2021. The total amount of denied dollars in fiscal year 2024 was a little over $210 million. And inpatient denials represented the largest proportion of those denial dollars in the data that we reviewed in 24. And this was a growth from 2021 from about 66 million in 2021 to over 116 million in 2024. The overall claims also increased again alongside those denial dollars, and this was represented by approximately 835 million in 2021 to almost $2 billion in 2024. So the overall claims and the cost of care is also increasing. If in order to put this into perspective, those overall denied claims was about $47 million, which is approximately 6% of those claims in 2021, and it increased, and in 2024, it was around $72 million, again, keeping that in proportion, which was approximately 4% of those total claims in 24. Next slide. So on average, those total claim dollars were approximately 93 million in 2021, with the average of denial dollars around 5 million. There is a lot of variability within that, those denial dollars across our managed care plans. In 2024, there is an average total of claims of 206 million, with the average denial dollars of around 8 million. Next slide. So our regulation authorities and oversight for Maryland Medicaid, we'll go over that. Next slide. So Medicaid requires a high level of reporting on pre-service and post-service activities in accordance with our federal and state monitoring plans. Our ECRO, our External Quality Review Organization, provides a quarterly and an annual report on our grievances, appeals, and denials. You can find those reports listed on our quality website on the link provided. We also provide an independent review organization, Case Reviews. This is an opportunity for facilities to finalize their dispute with MCOs once they exhaust the MCO appeals process. We also operate a complaint process for both members and providers. Our complaints resolution unit is part of our call center for members and providers to file their complaints, ask questions, get assistance, and report any anomalies to the denials process. And our nurses do investigate those complaints and follow up. We also have the provider network services, which is another avenue for providers to submit complaints about how claims were processed with their MCOs. And we also provide some level of mediation through that route. We conduct limited scope audits to ensure MCO rules and regulations are applied accurately and consistently. So not only are we checking to see if MCOs are following our rules, but also are they following the criteria that they establish for themselves and communicating those to providers. We also have the authority to impose sanctions. We may order MCOs to provide or reimburse for services that have not been appropriately denied. Our care transformation or clinical transformation unit, which is our team of physicians internally to Medicaid, do provide ad hoc reviews of complaints that get elevated from any number of these units. So from our IRO, from our ECRO, from CRU, as well as from our provider network services. Next slide. Next slide. Okay. So I wanted to give an overview of our regulations, and we've been talking about defining some of the terms that we're using, and we do have a definition for denials in COMAR, and the link for COMAR is included in this deck. So I'm not going to read all of this, but this gives you a starting point as we're having those discussions. Next slide. There are additional regulations I included here about denials and the oversight. We have the federal regulations that establishes coverage parameters. Those MCOs are allowed to place appropriate limits according to criteria for the purposes of utilization control and that cost containment. And MCOs are required to maintain consistency in their decision making. Our COMAR rules outlines a complaints and appeals process, as I described. We also establish timeframes and parameters for the decision making. We describe the enrollee appeals process as well as a state fair hearing process for members when all else fails. Next slide. So this is another federal rule that the Medicaid agency must provide an appeal procedure for providers. This is particular to fee-for-service, and fee-for-service also has an outlined utilization review process and requirements, and also outlines their appeal procedures as well through these regulations. Next slide. For fee-for-services oversight, there is a complaint process for providers, also to ask questions, seeking assistance, reporting any anomalies within the fee-for-service denial process. We do have an internal team that provides oversight for that, and they will follow up with an investigation into that complaint. They also conduct quality assurance and audits and trainings to ensure that the contracted utilization review agent is making those determinations in alignment with our guidance. They also offer multiple appeal avenues, asking for reconsideration of certain reviews by that UCA, as well as administrative review by the department. Our clinical transformation unit is also very closely involved with that team as well. And providers also have the option to appeal to the Office of Administrative Hearings. Next slide. So I wanted to bring in some of the recommendations from the Medicaid and CHIP Payment and Access Commission, or otherwise known as MACPAC. So in 2024, MACPAC responded to the increase in adverse determinations through a review of Medicaid denials and appeals process. They reviewed federal policies, they did a state policy scan, as well as interviewing certain state and other stakeholders, representatives, and they also conducted focus groups with beneficiaries. Next slide. So this slide gives a brief overview of their 7 recommendations. 1, 2, 3. Yeah. So Medicaid has implemented at least 3 of these recommendations fully. We do have 2 of the recommendations that are still in process, and we're finalizing those processes. And then we have 2 that are still pending. We definitely have increased our communication with MCOs about how to communicate their criteria with their members and providers. We are collecting and reporting data on these denials in different ways. We definitely are looking into conducting routine clinical appropriateness audits. So we have established an audit process that we are continuing to refine. That audit process does elevate certain outliers to the CTU, and we may issue memos for corrective action towards certain MCOs when we do find anomalies. Each of the MCOs are required to report on their websites data about their prior authorizations and denials. And we are still working towards a independent external medical review process, as well as looking into the feasibility of the extension of timelines. So while a decision or a determination is in dispute, would that particular beneficiary continue to receive those services? Next slide. So we wanted to give some recommendations for this work group on next steps that we hope you would consider. So on the first step would be infrastructure. Infrastructure, infrastructure, infrastructure. I cannot I cannot emphasize this one enough. Really looking at establishing best practices for accountability, developing state regulations on the application of AI to utilization management, and also considering what that foundation looks like, who carries out the work, what connections and resources are available to carry this work forward, what those levels of responsibilities are, and then making sure that all of the agencies involved are addressing the matter in a similar way. Next slide. Data. We want to make sure that our policy and decision making is based on data, that the data informs our next steps. And what's very important, as we've seen in this work group, that we may have different terminology that we're using. We want to make sure that we are standardizing how we're talking about data, what data we're looking at, how we're defining that data. And we want to move forward to help identify the common denial reasons across each of the payers. We want to establish comparability between commercial and Medicaid denials, even providing some stratification. Are there certain areas of by geography or by payer that are outliers? Ultimately, we really need to understand the drivers of denial trends and associated costs before we can come up with solutions. So why are there outliers? Why is there variability? Why do we have this increasing trend to begin with? And getting to the root causes is going to be a critical next step. Studying the impact of denials on health outcomes. All of us are involved here for the betterment of our beneficiaries, and we want to make sure that our beneficiaries have the healthiest outcomes possible. We want to establish expectations. So how do we achieve a balance between cost containment in this atmosphere of a budget crunch and limited funds and resources, and still provide the best standard of care? Next slide. Collaboration. And in the spirit of this work group, we have a variety of stakeholders from many different areas in healthcare as well as in government. And we want to leverage those existing relationships. We want to be able to consult with other states who are facing similar problems. As I said, this is not an issue that's unique to Maryland. And other states are tackling the same process and the same type of investigation. So what can we learn from other states to build upon what they've already achieved? We don't want to reinvent the wheel. There may be ideas out there that this group hasn't considered, and we want to tap into that. We also want to share resources. Medicaid has a limited amount of staff, limited amount of funding. What can we do to tap into the resources of our stakeholder groups and share those resources within this work group? It may be data, it may be some legal analysis, policy overviews, something that this group could potentially contribute to Medicaid. Next slide. We've heard some of the complaints from the group about downcoding, audit requests, some variety in how we're defining and interpreting clinical criteria for medical necessity. And we want you to reach out to us. We want to know more about concrete examples of those cases. If you have a concern, please give us particular examples with the information for that Medicaid beneficiary or the provider that has a concern so that we can do a deeper investigation and again, continue to do the root causes to understand the issues better and to better be able to rectify that situation. Next slide. All right, I will open up for any questions.
Dr. Dixon, thank you for that and for your suggestions. I see some questions. Before we go to that, I just want to also welcome Chair Heather Bagnall has joined us as well as Delegate Gazzoni. So we have both of them now in the group. There's one question in the chat. Heather Little wanted to know, does the state review IRA appeal outcomes? Some payers have higher overturned cases through IRA appeals.
IRA, is that
I'm sorry, IRO. I'm sorry.
Oh, okay, the independent review organization. So the independent review organization is, as its name states, it's independent. Medicaid does not have the authority to overturn any of their decisions, but we do oversee that contract and we do set certain deliverables and criteria for those reviews to meet. So if you do have any questions about that, please reach out to us and we can address that with the IRO in terms of how they're delivering on that contract and those processes and provide some corrective action.
Okay, actually, let me.
But those decisions are final.
Thank
Yes.
you.
So can you hear me?
Yes, I can hear you.
Okay, great. Let me clarify my question. So it's not that the IRO is doing anything incorrectly. We're actually very pleased with the IRO. But our services are denied at the time of billing, and then they go through the 2-level appeal process with the payer who continues to deny it, not paying us for services. But as soon as it goes through the IRO, we have select payers that have very high overturn rates. My question is do you review the IRO outcomes so that maybe we can take some proactive steps in changing some of the payers' behavior moving forward on those types of cases since it's repeating?
Yes, we do. And we do track the data for those upheld and overturned rates for the IRO. And that is something that we do reach out to those outliers to find out what's going on, what their, I guess, perspective on that approach has been. And we do encourage them to work directly with providers to resolve some of those. There are certain providers who are also outliers who use that process. So we encourage communication and relationship between the MCOs and those facilities.
Okay, thank you.
You're welcome.
Thank you, Heather. We're going to go to some raised hands. Jai, do you want to ask your question, please?
Yes, thank you, Madam Chair. Thank you for the wonderful presentation, Dr. Dixon. I appreciate it greatly. Before I go to my question, I do want to explain that within the IRO, the loser pays the fee for the IRO, Heather. So that might give you some little comfort that if an MCO is losing consistently in that process, they're paying about $465 each time. So
Yeah.
over time, if they're continuing to lose, they might want to change whatever they're doing there.
Yeah, understand that, but $400 is really not compared to some of the size of the
I get it.
claims. Yeah, nothing. It's
Um,
not too much of a hand slap. Thank you, though.
Yes. As far as the presentation, Dr. Dixon, slide 13 had a startling stat in there that total overall claims increased from 835 million in fiscal year 2021 to almost 2 billion in fiscal year 2024. Can you give me some insight into what might be driving that increase in cost?
So, one of the things that we have come up with internally has been that unwinding process, or the pandemic and the large number of enrollees that we experienced during that time. The other driver may be just the overall increasing cost of care. We're seeing things like, cell and the CGT, the CGT treatments, pharmaceutical costs are much higher. We're also covering more. We have the doulas program. We're focused on maternal and child health, or improving our focus on maternal and child health. So there are a lot of aspects that are going into those increased claims. And again, something that we do need additional resources to continue to dive deeper into a root cause analysis for what those underlying reasons are, as well as how much of that is contributing to the reasons why our denials are increasing.
Sure. Thank you, Dr. Dixon.
Thank you, Jai. Dr. York? Unmute.
You're on
Dr.
mute.
York. Yeah, unmute.
There we go. Yeah, so thank you. Yeah, this is a good start to help us get some insight into this. And many of the MCOs for Medicaid also write in the commercial market. And so there's a lot of cross-platform ability to analyze workflow, denials, costs, and that type of thing. So has the department taken a look at that? Because the data is there to look at the relative percent denials on either side, and to further break down the data beyond that. The thing that occurs to me is that the whole denial infrastructure is expensive. The people that review, the physicians that are involved in peer-to-peer, and if there's such a high percentage, and we've just talked about this at the AMA meeting that I was just at, one of the delegates from Maryland, that if the whole denial process can be done more efficiently so that there's relatively low overturns in the long run, then perhaps the infrastructure would be less and things could run along more efficiently and patients could get more rapid and efficient care.
Well, I think that's what this work group is charged to do, and we're very interested in learning more about the thoughts of the stakeholders in this group. What you're describing, the efficiencies is important, I think, for both providers, member behavior, as well as the payers. So I think as we are learning more of those reasons, and doing that root cause analysis, that can help us figure out where those deficiencies lie and what areas are a priority to tackle going forward.
Has there been any look at the commercial versus the Medicaid when a particular organization is in both markets to look at comparability of that data?
No, I don't believe we have that data internally. I can check with our team to find out more about that. We do not have that commercial data available on an ongoing basis. So that's a great question. I think what's needed is an understanding of the differences between how those commercial is applied versus Medicaid. Medicaid has strict criteria from the federal government as well as our state. Medicaid operates a little bit differently from commercial. Our beneficiaries, the characteristics of our beneficiaries are also very different. Our beneficiaries are struggling with some of the social determinants of health. That also plays a role into to how their care is experienced. So I hear your question. I struggle with it a little bit. I don't know if we can necessarily compare apples to apples and oranges to oranges at this point, but we're looking forward to some of the thoughts from this work group on how we can do that better in the future.
Thank you.
Thank you, Dr. Dixon. Patrick Carlson from the Hospital Association.
Thank you, Dr. Dixon, for this presentation. I really appreciate the thought that's going into some of the proposed recommendations or items for consideration, particularly like the inclusion of additional data on denials. We recently submitted a comment letter in support of that effort at the Healthcare Commission to include denials data into the medical care database. And so we think that's great. And also really welcome the recommendation to be looking at infrastructure, best practices, and I guess opportunities for more standardization across payers for utilization review generally and denials. And so I think that would be great. And to have some of that data presented in a public way, the denial data in a public way that's available to, really a consumer who can access it easily. One question I had was about the limited scope audits to ensure MCO rules and regulations are applied accurately and consistently. I think my question is, how frequently do you conduct these audits, and what are the triggers for them? And the reason I ask is because a real priority area of concern for a lot of our members that's emerging are some audits that are being conducted by MCOs and the third-party entities, the vendors that they use. These audits have increased in volume. There have been real challenges with inaccuracies. And in some cases, significant cases, there's been misapplication in the audit standards referencing CMS rules for payment of medical and surgical services, for example, when the applicable rules that should apply in those rule sets are HSCRC rules. So when you see a type of pattern or practice like that is really causing a lot of disruption, what is the role for these limited scope audits? Is this the type of tool that you would deploy to address that kind of issue?
The limited scope audits, as I described them, are primarily on a case-by-case basis. So we have implemented an auditing process for those pre-service prior authorizations, where we're reviewing some of the MCO clinical criteria and how they're making their decisions according to those criteria. We do elevate certain cases and complaints that come through our complaints resolution unit or our provider network services when providers do have a certain issue with how certain claims have been processed by the MCOs, or if a member believes they truly need a service that is medically necessary, their provider believes it's medically necessary, and it just doesn't meet that MCO clinical criteria. So we do get involved in that aspect, and we may audit the clinical criteria across MCOs. So that's pretty much what I mean by the limited scope audits. We have not been involved in the third-party audits that you're describing. We have asked, and again, that was the last slide, our recommendation for hospitals. When there are particular cases or patterns that you're recognizing, we want you all to reach out with us, but we do need specific details. We do need MA numbers. We need provider names, provider types, which MCOs are involved. If you are seeing those types of practices or pattern of practices, we do need to be aware about it with specific details so that we're able to further investigate it, perhaps from a compliance point of view, or is the MCO unduly increasing a barrier to care? And that's our compliance oversight for the MCOs. I don't know if MMCOA wants to address that question as well. They may have a little more insight into what those practices are, but I think they're going to be presenting later, so maybe hold that question for them.
Okay, Patrick. you
Next
finished?
question.
Thank you, Dr. Dixon. Delegate
Thank you.
Pam Gazzoni.
Thank you, Madam Chair, and thanks for the presentation, Dr. Dixon. It was super helpful. I had a question, and I'm pretty sure that it was on page 24 of your presentation. You had a bullet about establishing best practices for accountability, and I didn't write the rest of it down. I just sort of paused there. And if you could just talk a little bit more about that, I wasn't really clear what that looked like and who all might be involved.
Yes, so establishing certain thresholds. So we're talking about an increase for in denial trends. What should we be expecting at this point in time? You know, is that appropriate as the total cost of care is increasing, as our claims dollars are also increasing? What is the trigger point where we need to provide some sort of corrective action or disciplinary action? We don't have that clearly defined, and we would like to see or get some assistance or expertise in better understanding what those trigger points need to be. And then also at what point, and define that for not only Medicaid, but also on the commercial side as well. You're welcome.
Thank you. And Delegate Kerr.
Thank you, Madam Chair. Dr. Dixon, regarding HR1 and the work requirement eligibility and the 115,000 who are going to be affected by this, do we know how many are already in compliance with that requirement, and how many are going to face some difficulty in staying on the rules?
That's a great question, and it would be nice if the field goal didn't constantly move. I think, you know, our teams have done a really good job in trying to prepare for the implementation of HR1. And I don't know if you're aware, but we had a lot of flexibility as this rule initially came out. They issued a new rule on June 1st that we are analyzing, and unfortunately we have to sort of regroup on that one to sort of make some revisions to our strategy. I do not have a new number for that now that the rules are changing, but I can definitely bring that back or bring an update to you all before the work group concludes, if you'd like that. You're welcome.
Okay. I don't see any other questions for Dr. Dixon. There might be one more. No, there's something else in the chat. Dr. Dixon, thank you for an excellent presentation.
Thank you.
Patrick raised his hand again. Patrick Carlson, you have another question?
Yes, thank you. I was just going to put it in the chat, but I think on the question of uniformity, one question that's come up is down coding. You know, the MIA recently issued a bulletin clarifying that down coding is not permitted under Title 15, 1005 of the insurance article. And I guess my question is does MDH planning on issuing a parallel bulletin that's applicable to the MCOs in alignment with that interpretation of the statute?
I don't have any information on that at this time, but again, it's something I can check internally and bring it back to the group.
Thanks so much. That'd be great.
Thank you. Dr. Dixon, I do see one question from Kimberly. Is that provider email address, second to the last slide, one that can be shared with providers that file complaints with our agency about denials and processing issues?
Yes, that is the perfect email for providers to use.
Okay.
Please, yes, use that. Make sure that you're including contact information, dates of service, the type of denial, and any relevant information for that enrollee that was affected.
Thank you. I don't see any other questions now, and really thank you for that excellent presentation, Dr. Dixon. I know we'll continue to work together through the work group. Next, we have another presentation from Matt Celentano. Matt is representing the League of Life and Health Insurers of Maryland. I think we'll see a little bit different presentation, but Matt, are you ready to start?
I am, Madam Chair. Thank you. Well, good afternoon, everybody. Like Chairman Beidel said, I'm Matt Celentano. I'm the Executive Director of the League of Life and Health Insurers of Maryland, so your state trade representing the commercial carriers in Maryland. And I'll try not to repeat some of the general sort of duplicate approaches that exist in the Medicaid program that Dr. Dixon presented on. But my sort of aim today is to frame the purpose of this presentation as to sort of change a little bit of the script and provide accurate sort of context before drawing policy conclusions about adverse decisions in Maryland. And one thing that we talk about a lot in Annapolis, and it continues to be important here, is that Maryland's insurance marketplace and the general ecosystem is pretty fragmented. And because of that fragmentation, there's complicated nuance that will affect different populations different ways. The Maryland Insurance Administration is one piece of a much larger, more complex ecosystem, and understanding its limits is essential before we have sort of honest analysis about what we're trying to do as a group here. This is a 25-26 work group, right? And the data we have is newer than ever, but it's still sort of incomplete. And in prior meetings of this work group, we had seen some data that came from as early as 2020, 21, and 22. And I think that we all know that that data is fairly tainted. And it's for obvious circumstance and reasons. But as we move forward, and one of the slides you saw before was a dramatic explosion of the amount of cost that is associated with some of the claims, right? And yes, is it influenced by people that got more care post-COVID? For sure, but it still outpaced any trend upwards. And we continually, year after year after year, see medical costs outpacing inflation by a ton, right? So health insurance in general is really expensive. It's really expensive because healthcare costs are out of control. And one of the jobs of the carriers is to be a sort of financial steward of that place, to make sure that we have accessibility and affordability for Marylanders. And that is only going to be heightened with the coming HR1 and the coverage loss that I think we all are expecting to see. So that's the beginning. Next slide, please, Craig. So this is the piece of the pie that sort of frames how we all need to be sort of talking. The MIA, with the regulatory authority over the commercial market, is only about 17% of the total insured lives in Maryland. The fully insured group market and the individual markets, that's not a ton. The majority of Marylanders get their coverage through channels that the Maryland Insurance Administration cannot regulate it. The biggest group being that self-insured market. We got Medicaid, Medicare, and federal employees program, and the military. All of those groups are outside of the MIA's jurisdiction. And because of that, we have different experiences for different populations. This is not a criticism of the MIA. It's just a structural reality shaped by federal law. But it's the essential starting point for any honest policy conversation that we need to have. So this slide I will sort of refer to. I refer to it all the time in the spring and will continue to, because anything that the General Assembly does really only applies to a small sliver of that total insurance lives landscape. Next slide, please, Craig. So why does that fragmentation matter, right? Well, that fully insured group plan, that's 540,000 lives in 2025. You know, we're a state of roughly 6.5 million. The individual non-Medigap plans are roughly 300,000. Adverse decisions, grievances, external complaints from regulated carriers. Yes, the MIA's data can tell us a ton about that. but we already provide a quarterly report with claims and enrollment data to the MIA required by law. And the grievance outcomes and IRO external review results also go to the MIA. That's the full commercial marketplace. The MIA's data can't tell us, which is the majority of lives in Maryland, about 1.3 million lives are in that large group self-insured plans. There's no MIA oversight on that. And in most cases, well, actually all the cases, the insurer they're not the insurer. They're just a third-party administrator administering the plan to the folks that are shaping the policies for themselves. We have roughly 456,000 federal employee lives governed by federal law, by the ERISA program. No oversight from Maryland. And the denial rates or prior authorization policies of self-insured employees, we don't have insight into that. Those HR teams are the ones that determine the approaches. The self-insured plan grievance and appeals outcomes are a totally different world, and adverse trends among that 68% of the insured marketplace are outside of the MIA's jurisdiction. What I want to say, to go back to sort of the first, second, and third work group, the denominator matters, right? It's one thing to come into a public setting and say there were 16 trillion, denied claims last year, or but what is that? What is the denominator? Because the reality is that the vast majority of those denied claims have reasons, and we'll get to some of that in a bit. But cherry picking every bad example isn't the reality of what is happening in the marketplace. And it also is a good time to go back to that fragmentation, because the provider experience varies greatly because of that fragmentation. Maryland passed a national leading prior auth utilization management law a couple of years ago from the leadership of Chair Beidel and co-chair Kerr. But if you are a provider running around from appointment to appointment, you might not really experience that streamlining of prior auth, because you're only 17% of your patients are those laws applicable to. So it is really important to know that the provider experience, unless you know exactly what patient with what kind of coverage you are seeing, your experience is going to be different. Can we go to the next slide, please, Craig? So what does the data actually show? And this is the interesting portion, I think. The numbers in context are actually encouraging if you go back to it. 93% of medical claims are approved after final PA review. And the final denial rate nationally is less than 3%. There are big numbers about how they're denied claims, but there is a robust review process. There are avenues for consumers to actually go through to appeal that process, and a lot of them are overturned for a lot of reasons. There are coding errors, there are eligibility issues and changes. For example, during the redetermination process, there were a lot of folks that were no longer eligible for Medicaid and got commercial plans. But if Medicaid denied you because you were no longer eligible, it's listed in the denial rate, but that person is no longer on Medicaid. So we have to take that into context. There are coding errors all the time. And we have heard now 3 or 4 times about downcoding. Well, downcoding is illegal, but we see upcoding from providers all the time. So we're reviewing those kind of claims. This is a financial transaction adjudication is important for the solvency of the market. We see duplicate claims all the time, especially with the advent of AI. Carriers are not allowed by Maryland law to deny a claim deny a service with using AI, but we are getting bombarded by hospitals and by providers utilizing AI to send claims over and over and over and over. And if you deny one of those claims because you've already adjudicated and paid one, all those other AI denial claims, because you paid it already, go into the denial bucket. So separating all those actual numbers is really important as we move forward. Absolute denial numbers within the regulated segment sort of reflect a smaller pool. It's not necessarily a deterioration of carrier behavior. These raw counts of data reflect market composition shifts rather than insurer conduct changes. So is there a lot of work to do? Yes. Are there opportunities for partnerships here so we can get to better places? Absolutely. But this fragmentation and the marketplace always changing is definitely something that we have to keep, to stay on top of. But I will say it over and over, there is genuine common ground here, and we need to find ways to keep moving forward. Could I have the next slide, please? So concerns about denial trends, right? So we have seen in the past couple of years data that shows absolute adverse decision counts have increased in recent years. Sure, there have been more, but the denominator has grown exponentially. Hospital-based care and mental behavioral health represent high denial concentration. That's what we've heard over and over. If you look in the denial reports from the MIA in the past year, ER denial rates, which were a big talking point from some stakeholders in the past year, actually went down 30% last year. There are some trends that we want to address, and this work group is a great place, especially in pharmacy, but I think there's a lot of factors that go into the pharmacy denial rates, including the fact that about 10 or 12 years ago, the percentage of your premium that went to prescription drugs was roughly 10%. This year, it's about 35%. If we don't get a handle on the exploding costs of prescription drugs and how it impacts affordability, we're never going to be able to offer a product to the consumer. And that's what I am terrified about. Critics argue that high denial rates reflect profit-motivated, not medically driven decisions. And I would say to you, the carriers are the only stakeholder in the entire universe that has a medical loss ratio that limits the top end of their profits. It's usually, it is less than 3% profit margin per year. The hospitals, the doctors, the pharmaceutical manufacturers, the device companies, none of them operate with a cap on what their profits are. And we can see that through HSCRC filings. So the context that the data requires is really important. That raw adverse decision count, it's not normalized to claims volume or enrollment size. We have a growing individual market for a variety of reasons, is up to 8% in 2024. That naturally produces more initial denials. Most denials are overturned on internal grievance review, which you talked about before. That's a working safeguard, and it is working. But the vast majority of these claims that are denied are because of errors. And that could be you entered the wrong address into the actual forms. Many initial denials stem from incomplete provider submissions, like I just said, not medical judgment. And the market's ERISA-governed self-insured majority operates without comparable data reporting. So we are missing a huge chunk of the Maryland population, and that is a problem. Next slide, please, Craig. So what is happening at the national level? And I am sure that many of you have seen some of the press releases around from AHIP mostly, America's Health Insurance Plan, which is the state or the trade for the national carriers. And they, in the past year, have instituted this voluntary proactive approach from insurers. And that being said, Maryland is already ahead of what the national trends are doing. Maryland is going beyond what the commitments are from carriers across the country. That's not to say that we should stop where we are. That's just to say let's level set. But 96% of prescription drugs and medical claims are not subject to prior authorization in the commercial market. 96 aren't subject to any prior auth. 97% of medical prior authorizations were ultimately approved in the commercial marketplace. We've seen a 30% reduction in prior auth requirements announced by a couple of different insurers, but that's the trend we're seeing. And overall, in the last year, an 11% reduction in prior auths. And then 100% of all plans in the country, AI is not used alone to deny PA requests. And in Maryland, we obviously passed House Bill 820 in 2025. So the national efforts are in the news, but frankly, they're catching up to Maryland, I think is the best way to put it. Next slide, Craig, please. So the question is, what do we do as a group as we move forward through this year and beyond? Well, there's a lot of policy considerations for the work group, but there's a lot of efforts also at the national level, and we should try to capitalize on some of those and move forward. But we should consider whether full year enrollment and claims denominators would help provide useful context before we sort of draw trend conclusions. We should explore whether voluntary data sharing from self-insured administrators could supplement MIA reporting. If we don't have that 40% of the marketplace and see what they're doing, it's really hard to figure out what the actual provider experience is. We should examine how PA denials relate to other adverse decisions, in those categories to support more nuanced analysis. The devils are in the detail in the data for sure. And maybe we should assess whether additional carrier level context would help regulators and the public interpret reported figures. I am not under any assumption that the public is ever going to understand the fragmentation of this marketplace, but for all the smart people on this call, it does matter, and you're all bright enough to get it. Second part, I want to just sort of a quick review of Senate Bill 791 from 2024, which is still in the sort of its infancy of implementation, but we are going to get towards electronic medical records, especially, well, it's really for e-prescribing systems where we see the vast explosion of denials. So that's really important with real-time auto approval for qualifying requests. Real-time benefit check has the sort of ability to take us to a new level that will put behind us all of some of the policy fights that exist on paper, right? And the back and forth that we have that slows down sort of timely payments. So for coming from the perspective of others, we can get through that and go to instantaneous decisions. That's going to speed up things in a significant fashion. Chronic condition prior auths. There's no reauthorization for up to 1 year and that's a huge sea change and what most states are not doing. And no adverse decisions on reauth if the treatment is ongoing and the prescriber attests to continuation of need. That's a huge game changer. New enrollees. Carriers may not disrupt an active course of treatment without reauthorization. There's going to be a lot of churning going on in the next couple of years of people going all over the place. And to be able to honor those requests across insurer or marketplace is really important. There's continuity of PAs. Prior authorizations honored for up to 90 days on a patient change plans. If you leave Care First and go to United Healthcare or Cigna, the carriers have all agreed to, not just here in Maryland's law, but across the country to honor those requests. And a 60-day advance notice required for any new PA requirement takes effect. And that's important because some of the things like we're trying to address the high cost of drugs, formularies are changing all the time. New drugs are coming on and off the marketplace on a daily basis. And to be able to keep up with some of those schemes is really important. And then the regulatory scope. We have to acknowledge ERISA preemption limits on self-insured plan regulation. We should probably explore DBM and the state employee plan as a model for sort of voluntary MIA external review. We should coordinate with CMS on Medicare Advantage prior authorization oversight. And we could build a legislative record documenting the close to 70% data gap before mandating carrier-only changes. So we continue to just address like I've said many times now, we just address that 17%. For a lot of the providers, they're not going to notice the difference. And it's one thing to make us feel good. It's sort of like a sugar high is the way I feel about it, that we are making progress on that 17%, but we're not addressing the holistic sort of nature of it. And that is our challenge, right? But we have great leadership here, and I think we can make sort of progress on that front. Next slide, please, Craig. So some key takeaways, some food for thought. The regulated market is a minority. We have work to do, and there is a huge gap. But there are things that we can do together to try to find what is a smoother transition for some of the provider groups. The context matters for the denial numbers. I'm not going to go over this again. And the industry is moving in a voluntary fashion. They're being proactive. Nobody said that they needed to bring all these carriers, hundreds of them, together to get on the same page about progress we could make nationally. And although they're going to be catching up to what Maryland did, it shows that they are willing and able to partner to make it easier for all people involved. And there is agreement on goals, right? All parties, especially on this call, we want accessible, timely, affordable care. The work group recommendations should build on those shared principles. I'm sure that we can find areas of agreement to move forward with. And regulatory coordination is essential, right? Effective reform in Maryland is not going to matter, I think, overall, if it is just the commercial marketplace. We need to think broader, and I know that we can. But we get back to, what are a couple of things that keep me up at night, right? HR 1 keeps me up at night. I think it does for probably everybody here. We're going to see massive coverage loss. What happens to those folks? A lot of them are going to be utilizing the ER, and that's terrifying. Uncompensated care obviously costs 10 times more than it does to have a primary care physician. But I'm worried about the loss of advanced premium tax credits, right? We're worried about the HSCRC and the cost shifts that are going on to support, laudable goals, but they're on the backs of commercial carriers. And that is ultimately getting passed through to Maryland constituents through higher premiums. We have to be careful, right? And once again, medical spend is outpacing inflation every single year. Health insurance is expensive because healthcare costs are out of control. We have to figure out a way to sort of look at it more holistically. And like the last thing I wanted to say, and the coverage loss thing is terrifying. And I know that there are a lot of people that don't like prior authorization, right? It is a blunt instrument, as a wise person told me, but it is a necessary instrument to make sure that we can keep healthcare affordable and accessible to Marylanders in a lot of ways. We want to work together. I really appreciate the opportunity to sort of address this group. If I can't answer any of your questions today, I am more than willing to have side conversations, and we are looking to be a partner as we move forward this year and beyond. So thank you.
Thank you, Matt. I have a question in the chat we'll start with, I think. Since Medicaid MCO adverse decision data is already reported to MDH, would the league support the work group's standardized definitions and reporting, here's a word I don't know, taxonomy, applying across both MIA and MDH databases so the gap you described shrinks to generally unregulable ERISA plans?
Well, so adverse decisions are already reported to the MIA by law already. So I'm not sure that I think that this would be applicable to the commercial market. And I think that the prior auth prohibitions that were passed a couple of years ago are miles ahead of what exists in Health General and in the Medicaid marketplace.
And then this is Dr. Aditori. Slide 6, the 96% approval rate is great, but we need to understand better what the denominator is. If routine generic meds that don't require PAs are included in that number, then the 4% matters a lot more than it looks, because that 4% is concentrated in the highest cost, highest stakes medications, especially drugs, biologics, non-preferred agents. Could we see approval and denial rates for just the drugs that actually go through prior auth?
So that is the question, and I think that's something that the carriers would like to talk with the MIA about. And what we would like to dig down on is because we are seeing the outlier in the rise in adverse decisions has been in the prescription drug space. And I think that I have some theories on why that is, but I think that this group would be better served to try to understand that a bit better.
Okay, we'll make a note of that. Thanks, Matt. We have some other questions. Commissioner Grant.
Yeah, thank you so much, Madam Chair. So Matt, thank you for your presentation. Some really interesting recommendations. I look forward to discussing those as we get into more detail. I wanted to provide a few comments along the way on some of the context, because I just want to quibble with, I think, maybe some of the framing just a bit of what you said. I do think, though, on the whole, it's important points. First of all, just for folks generally to know, we're working on getting a Power BI dashboard up on our website coming soon that has our adverse decision data over time, so that folks will be able to dig into trends over time. And I think, Matt, I heard something new today, that carriers are framing some of the growth as the growth in the individual market. And while I appreciate that, why that might be happening, I have some questions about that, because there are sort of trends over time in the growth in the individual market. And at some point, it just makes me question about other market practices. So maybe we can take that offline and discuss that a little bit more. You said something about grievances that I want to clarify based on our data. So our so how the process works for our fully insured plans is we get data. There first has to be an adverse decision, and an adverse decision in this context is purely a decision based on medical necessity. So it's not a missing address. It's not those other denials that fall into a much bigger bucket of denials. This is medical necessity. You don't need this service. Only 10% of those decisions are actually grieved internally to the carriers. So I think, well, once they get there, over half of those are overturned and modified, which is great. Only 10% get there. And I think that speaks to some of the challenge in the processes that both patients and providers see. So I think that's some important additional context. I also just want to say that data sharing would be fantastic. And perhaps if the carriers are willing to dig into some of these questions about prescription drugs or provide, through offline non-carrier specific, that could help this work group do this work. I would love to have that conversation with the industry so that we can make sure that we're making informed decisions. And then, yeah, just finally, I think there are things happening in the prescription drug market that are important to discuss because they're clearly a growing cost driver in Maryland and nationally. And I think we need to get our arms around that. It's a concern when we're trying to address overall affordability. But I think there are also things happening within formulary development and prior authorization development that are worth discussing around this. Like, we need to get our arms around affordability, but we also need to make sure folks have access to clinically appropriate care. So I'll step down off my little soapbox now, but wanted to share those clarifications that I saw from your presentation.
Thank you, Commissioner Grant. Matt, do you have any responses to?
I'm always happy to work with Commissioner Grant.
Good to know. Let's see. Dr. Jacobs, let's go to you. I think you're still muted. Unmute.
Oh, can you hear me now?
Yes, we can. Thank you.
Great. Thanks so much for the presentation. I appreciate it. I also appreciate on the recommendations side of things. You pointed out electronic prior authorization. And so I wanted to ask a question because we're in the process of implementing this. And as we've been implementing it, we've noticed a couple of things. One, it's, to your point, it's part of the fragmentation. It doesn't necessarily apply across the commercial market and Medicaid. It's only on the commercial market, fully insured side. And so a question for the group would be electronic prior authorization. I mean, it can smooth some of the experience on the provider side and the payer side. And would folks be interested in potentially expanding some of those, the electronic use of prior authorization, some of the standards? And the corollary to that too is that after this legislation was passed at a state level, CMS changed, and in the legislation, there's two standards for pharmacy. CMS just proposed their own standard for pharmacy, and it includes the two standards that we use, but also includes a third. And so the question would be also, would we be willing to allow some more flexibility in the statute on the standards so we could keep pace nationally? Those are maybe some additional corollaries to the electronic use of prior authorization that we could consider. So curious if there's any reaction to that.
I think my reaction to that is in 2014, the Maryland required carriers to use electronic processes. Only the carriers, not the providers. So we're looking at an unfiltered marketplace. The 2024 prior authorization law just spoke to prescription drugs. I don't know how we do a real-time benefit check to all services unless the providers have the systems in place. They do not. So I think it's a laudable goal to get to the place where we're working electronically on both ends. But if it's only one side of the scenario, we're not going to make any progress.
That's a good point. Thank you, Matt. Let's go to Dr. York.
Thank you, Matt, for that presentation. I guess what strikes me with this is, as stewards of cost and as stewards of our ability to provide high quality care, how do you reconcile this high percentage of denials that are subsequently overturned? And as our insurance commissioner said, that nothing to do with addresses. I know I see it from my own practice, in our practice. I see it from the state level at MedChi, and then as a delegate to the AMA, and the same story is repeated at each scale. And from the peer-to-peer reviews that I've gone through, and I've had some discussions with the physicians that are asking questions, it's evident that they may be using AI to deny classes of care. But then when it comes down to, well, a physician appeals that, then there's a physician in the loop. But and I'm on the informatics caucus of the AMA. It's clear that a physician needs to be in the loop in the decision-making process before the denial is made electronically. And that's a key component. And that's not happening now. And we're formulating policy at the AMA to address that. But I think that from an efficiency, from a quality care, and even in handling costs, because so much cost now gets dumped into this infrastructure for doing that, how do we rationalize this high percentage of cares of decisions that are then overturned?
That's a couple of point question. Dr. York, I appreciate your perspective for sure. I would respectfully disagree that we are using electronics to deny care. That is not the case. I will also tell you that there are lots of instances where I think that this group especially needs to look at that prior auth is not just only about cost control. And I'll give you two examples. All right, there is a particular person that I'm sure that most of the people on this call know in the universe of Annapolis that was experiencing a cardiac issue. Her doctor had changed her medication that was initially denied. And she called me and a couple of other carrier friends screaming and yelling about how we were trying to get into her care and denying her care, and it should be a conversation between her and her doctor. The doctor had changed the medication to a cardiac approach in this particular prescription that required a blood test to make sure that she didn't die. The doctor did not provide that blood test. The carrier caught it through the prior auth process because we have medical records that go through all different doctors that are associated with claims. That catch could have saved that particular person's life. That is another aspect of prior auth that we don't talk about enough. It is a safety control. I have another example. Was it within 1 week? Somebody else that many of us would know was experiencing cancer, unfortunately, and had a denial for the night before their first chemo treatment. That person ran to the governor. The governor called me and the particular carrier screaming at us to make sure that we do not, what are we doing? What are we doing? What are we doing? It turned out that the form was filled incorrectly by the provider. So there are all kinds of examples in this. And like I said earlier, we cannot just cherry pick the bad examples. Those are two particular examples, but there are millions and millions and millions of claims every year, and there are going to be outliers. The question is, how do we address those outliers to get a more uniform approach? And I think that's what this work group's for.
Matt, this is Senator Vidal. So your response to this large number of denials that have been then overturned and paid is just errors. It's not an attempt by payers to not pay a claim and maybe it won't come back.
Chair Bottle, I think that a huge amount of the denials are because of coding errors. I think there are other factors that we need to consider on what might have gone into a denial, and I think that's what this work group's for.
Thank you. Patrick?
Yeah, thank you. I think in response to Dr. Jacobs' question, I'm very interested in, this effort to apply some of these electronic prior authorizations, prior auth standards across other payers. I think we have a really strong prior auth statute that are applicable to the carriers. I think that those standards can apply to our Medicaid Health Choice MCOs. And we also have this new Medicare Advantage stabilization program that would give us the opportunity to establish standards for plans to qualify for state subsidized support under that program. I think that gives us an opportunity to implement standards applicable to Medicare Advantage plans that participate that. I think a couple meetings ago, I raised that we've been hearing from a lot of members concerns about delays in prior authorization for post-acute services that really are presenting challenges for timely discharge and throughput. So I would really think it would be a great opportunity for us as a work group to explore, you know, having strong standards for prior authorization across payers, not just the commercial carriers, but Medicaid and Medicare Advantage, where that opportunity exists.
Any response, Matt?
I don't think there was a question there, Chair Beidel, but I'm sure we're more than willing to work with Patrick and his team for sure.
Thank you. Thank you, Patrick. And now we have Dr. Dixon.
Excellent presentation, Matt. Thank you so much for sharing all of that information with us. I wanted to go back to, I think it was Dr. York's question before I get to my question. Those denials that are overturned, again, it goes back to those standardized data definitions. And I want to impress upon the group that we need to define the different types of denials. There's pre-service, there's post-service, there's different reasons for those denials. There's different categories of service. There's different provider types. And I think when we are pooling all of that information together, some of the nuances and the reasons for those denials gets missed. So it would be interesting for us to know what kind of denials are those. Sometimes providers do leave out critical information where there may be, in terms of a prior authorization, there may be certain clinical criteria that the provider knows or the physician knows that that patient meets, but they're not communicating that or relaying that to the insurer. And some education on the side of the provider may be needed, or again, going back to our recommendation for infrastructure, making sure that all those who are involved in that process are fully educated and prepared to make those submissions. So that's just my little soapbox. Now, my question, Matt, you touched a little bit on AI. We've talked about reasons that, or actions that AI should not take. What would be helpful for the insurers to be able to do with AI that will help improve efficiencies, improving our healthcare outcomes, making sure that we are making more appropriate decisions based on clinical and medical needs?
Thank you for the question, Dr. Dixon. I am not an AI expert, but I will say that there is promise in AI for efficiency. And does that mean payment of claims much faster, especially in the clean claim space? Likely. Is there a way to increase credentialing and enrollment and all those ancillary issues that happen in healthcare and the operational red tape? I'm sure, but I don't know if that I have a particular sort of gold standard to point to on AI, but I can certainly ask again and see where
Or maybe how are the plans using AI now?
Oh, I think it's mostly
maybe a level setting.
Yeah, I think mostly in the accounting and payment spaces, but I'd have to ask some deeper questions on that front, Dr. Dixon. I know what they're not using it for.
Yeah, we all know what they're not doing, but what are they doing? That's a, big question. Thank you.
Thank you, Dr. Dixon. We have Dr. Zama.
Yeah, good afternoon. Thanks for the presentation. I have a quick comment and a question. My comment is with regards to AI. I am worried about the use of AI alone without a human being monitoring what they are doing, because it is true that AI is going to help, but I think there still needs to be some human being at the end of it to make sure that whatever is done right. Because if we just rely and say, hey, AI is going to help, that is true. But I think the human intelligence should still be there to make sure that they verify, to make sure everything is fine. Now, go ahead. I'm sorry.
No, please, Dr. Zama. Sorry.
My question is regards to the prior authorizations. I understand all the going around, some expensive drugs and some things like that. What worries me is some patients that have chronic illnesses have been on the same medications for years. and we have to keep doing prior authorizations year after year. That worries me, and especially late last month, I have a patient with sickle cell that has been on the same medication, oxycodone and OxyContin, for over 10 years. I have been doing prior authorizations every year. This year, it was such a help. This woman went for over a week without her OxyContin. They requested several things. I submitted it. I requested again, the same things again, until I had to write a letter that if you keep doing this, I'm going to have to write to the governor and the legislators because this does not make any sense. So my question is, for somebody like a sickle cell patient that everybody knows that they have sickle cell, why should they be having prior authorization year after year if there is no change in the dose?
So, Doctor, I would suggest that goes back to the beginning of this conversation in my presentation, which is I think that fragmentation matters here. And my guess is that that particular patient that was on the same drug year over year did not need to go through a reauthorization, and it was probably not in the commercial marketplace. So I'd love to learn some more, and I'd be happy to talk to you offline, but this screams to me that it's not happening in the commercial marketplace and why this conversation is so important.
I don't see any other questions. Matt, thank you for your presentation. I'm sure we're going to have ongoing discussions.
Thank you very, very much for the opportunity.
Thank you very much. Finally, we have a presentation by Dr. Joseph Wynn, Executive Director of the Maryland Managed Care Organization Association, and Jai Sunari, President and CEO of Jai Medical Systems. So are you ready for your presentation?
Yes, ma'am.
Okay.
Thanks, Chair Vital. Craig, you can put the slides up. Oh, excellent, excellent.
Great.
Everyone hear me okay?
Yes.
Excellent. Chair Vital, thank you. I'm Joe Wynn. I'm not a doctor, but thank you for the promotion, Madam Chair. I'm the Executive Director of the Maryland MCO Association. Want to just thank the Chair and Commissioner Grant for the opportunity for us to share some slides today, and the MIA staff for assisting with the presentation details. Very helpful. My objective with today's presentation is to present a little bit about the association and share our perspectives around the topic of adverse decisions. As you know, Jai Surinine from Jai Medical Systems and Zach Peters from CVS Health are the representatives for the MCOs on this work group, and I'm joined today by Jai. We're going to walk through the slides together. Craig, next slide, please. So just a little bit about the association. We were founded in 2017 to advocate on behalf of the Health Choice program, the MCOs, and the people we serve. The MCOs work to finance and arrange care for approximately 1.2 million Marylanders who rely on Health Choice. And these are the members. It's 9 members. It's a diverse group of hospital-owned, provider-led, nonprofit plans and national MCOs. Some of our largest and smallest MCOs are provider-led organizations. The diversity of our organization's ownership structure gives us the ability to work together to solve disputes around programmatic areas such as this across the sector. I think everyone on this call probably knows, but Health Choice is the state's mandatory managed care program. It's a mature model with over 30 years of continuous operations. And because of its longevity, and the key leaders here are local. These are local leadership teams and local employment teams. It's a super mature program, and Maryland's blessed to have some of the most experienced Medicaid professionals in the country, both at MDH, but also at the MCOs. Next slide, Craig. So brief history. Did I skip a slide? I think I may have skipped a slide. Hold on. No. Go back one more. You're good. Sorry, Craig, one more. No, and again. There we go.
Yeah.
As everyone probably remembers, Health Choice was founded in 1996 and launched in 97. It's had considerable growth over the course of the years. Started off as a fairly small program In 1997, with only around 300,000 enrollees, it's grown quite a bit. It started off as a $3 billion program. Today, it's a $14.6 billion program. Along the way, considerable amounts of benefits have been added. And then since the inception, the program's received 7 renewals of its 1115 waiver. It operates as a waiver demonstration, which is a sign that it's received bipartisan support from the federal government across a lot of different years. We're now in a new environment with the AHEAD model. And for the MCOs, what this means is, in addition to the changes that'll occur with the global payment system and everything, for us, it's really about the investments that we're going to be making and are making in primary care through the Medicaid path, but as well as the health-related social needs screenings and the SDOH screenings that will be getting underway as well. Next slide, please. Oh, well, I was hoping my cool graphics would show up here, but they didn't. This is just some perspectives about the work group. And I think everyone knows that the MCOs, as stewards of state resources, we have obligations to be stewards of the state resources and look at fraud, waste, and abuse and make sure that the claims that are inbound are appropriate. We take our fraud, waste, and abuse detection obligations seriously. The MCOs aren't allowed to use prior auth for claims decisions or decisions that involve medical necessity. That's driven by legislation that Matt referenced from 2025. I believe it's House Bill 820. And then one of our tasks as MCOs is to reduce inappropriate utilization, making sure that care is delivered in the most cost-effective manner, and that's driven by COMAR, but not necessarily for the convenience of the member. It's about right site of service. And then lastly is we have quality obligations that we're held accountable to by the department, and they drive a lot of our activity and investments over time each year.
Joe, if I could interject for a second there.
Of course, Joe.
Good afternoon, everyone. The quality is critically important, and it's something that we didn't have pre-Health Choice. We didn't have NCQ accreditation requirements for all of the recipients and managed care organizations. We didn't have HEDIS reporting back then, and all of these things I think are improving the population health status for the Marylanders that are served by the program. I also wanted to talk about being the obligation as being a steward of state resources. That means that we, like the other carriers, are subject to an 85% medical loss ratio. That means that it's the intent of the program for us to spend at least 85 cents of each dollar on healthcare. And if we don't, that money is clawed back from us, and the state gets that money back and shares it with the federal government. The other thing I wanted to mention is that, for many years, as the state is developing its budget, they view us as part of the cost containment solution. We're looking at significant budget deficits in the future, and without managed care, it will be highly difficult to control those costs. And part of our role is making sure, as you pointed out, Joe, that we only pay for claims that are appropriate, that we're detecting fraud, waste, and abuse as part of our role. And I know that you all know that within the headlines, you see that there's fraud emphasis now on a federal level. That's part of what we do, is that we conduct site visits of providers to make sure that they are legitimate. And I think that's essential in ensuring that the dollars that we are charged with, that we are honored to be good stewards of, don't go to waste.
Thanks, Jai.
Yeah.
Thanks, Jai. And a good perspective to add on to Jai's comments is that in 2024, the MCOs paid out $6.41 billion in medical expenses to providers, and that's with a combined MLR of 88.1% across all MCOs. There's quite a bit of claims volume in the program. It's a big program. It's fluctuated a lot with COVID and redeterminations, and we'll address that shortly. And on quality, Jai's right. It's day to day. Much of our dedication is to this focus. It's reviewed annually with the department and directly linked to the HEDIS measures that we have obligations to attempt to meet. And we're very proud of the quality programs that the department has had. Next slide, Craig. So we wanted to include this definition. It's from the IRO, the Internal Review Organization section in COMAR. It's really linking the adverse decision to what is determined to be a medical necessity. And there have been some conflation around the term, and the reason why we want to bring it up is because what is and is not an adverse decision is important because it triggers certain rights and appeals rights. There are important distinctions around denial types, and it's important to remember that the bulk of denials occur for administrative reasons. And it's not clear to us that the data that's been shared in this work group or in other committee sessions and briefings before the General Assembly, if the distinction's clear in the data.
Yeah, Joe, again, that's spot on. I know that Matt had one slide that he didn't necessarily highlight where he said, and I'm kind of, jumping ahead of us a little bit. The adverse decisions we don't view as the same thing as claim denials. They can, it's not mutually exclusive, but adverse decisions we look at within the realm of pre-service, typically in medical necessity. But claim denials can be for a variety of reasons, including eligibility, which is going to be critically important as we look at HR1 and the churn that we're going to see in terms of the work requirements and the 6-month eligibility checks. But we don't view that as necessarily as an adverse decision.
Thanks, Jai. Very good point. And another data element point is really COVID-19 and the public health emergency. COVID-19 created a very sharp V distribution and some irregular patterns of utilization, to say the least. One of the things that COVID showed us was that health choice is stress tested and scalable, which it certainly was. It went all the way up almost to 1.9 million members at one point, or 1.8, sorry, and is now in health choice down to 1.2. So that's quite a swing. And we think that the data, it needs to be viewed through this PHE lens to understand the implications of all that churn. And that's true, of course, not just for PA, but also for any kind of utilization review elements of these claims. You can imagine a scenario where somebody loses eligibility because of a procedural disenrollment, goes to see a doctor, that claim gets denied. They subsequently could get a subsidized commercial product and then become eligible again. And there's a lot of churn, a lot of confusion, and the data may not reflect that. Next slide, Craig, please. So again, this is just to put a fine point on it. And Jai, I don't know if you want to speak to this, but we wanted to include this to make it crystal clear that not all claims denials are adverse decisions, and not all adverse decisions are claim denials.
Right, and I do think, and I think it's great that we've got it as part of our draft work plan here to define what we mean by adverse decisions. But we haven't really been operating as a work group with a clear understanding between the two. Claim denials and adverse decisions need to be defined. We need to figure out exactly what we're trying to tackle. If it's within the realm of adverse decisions, great. But if it's both, I think it's a little bit of a different conversation. And we would need to get a little bit more granular on the details of the claims data that's been presented thus far about what represents eligibility denials or benefit denials versus medical necessities type decisions, which I think is more within the realm of adverse decisions. So,
thanks, Ryan. Craig, next slide, please. Excellent. We talked a lot about prior authorization, and in the context of medical necessity determinations, they could be considered adverse decisions if a prior author request was denied for medical necessity. Prior authorization is a critical component and management tool for Medicaid as well as commercial carriers, but in Medicaid, it's incredibly important. It's not just to ensure that services are medically necessary, but that they're cost effective and appropriate and aligned with clinical standards. Matt mentioned the patient safety component, especially around pharmaceuticals. There are a lot of contraindications that are checked for. There's care coordination components to review the identity of perhaps better alternatives for care or gaps in care. But there's also a critical fiscal responsibility component. Medicaid is a major part of state budgets, and Maryland's no different there. We have a challenge as a state with our fiscal situation over the last couple of years, and it appears that the next couple of fiscal years ahead of us look the same way. We need to ensure that the services align with evidence-based standards and the right care at the right time in the right setting. So prior authorization is a critical tool. I need to acknowledge, of course, that the reforms that we've seen to prior auth are driven from the fact that it is a blunt instrument, as Matt said. There are burdens and delays, administrative loads, and that's why there's been such an emphasis around reform, both here in Maryland, but also at the national level. And you'll start to see some of those reforms kick in as we get closer to 27 with some of the FHIR APIs that folks at the department and others are working on to create better data sharing. We're not there yet, but it's in progress. Next slide.
Joe, just one more thing to add on the prior authorizations, especially within the context of pharmacy. I think Matt had alluded to the increase in pharmacy spend that we're seeing. There are these unicorn drugs out there that cost $40,000 a month. And as responsible stewards for the state of Maryland, Medicaid program has to make sure that utilization is appropriate. And that's why we have PAs. I think, it's not just to put red tape in place, it's to make sure that the dollars we're spending on behalf of the state of Maryland are spent wisely.
Yeah, 100%, Jai. And pharmacy is a big driver year over year. It far outstrips regular medical inflation, and medical inflation far outstrips regular inflation. And we saw a massive increase in Medicaid pharmacy costs from 19 to 23 as well. And a lot of that's driven by cutting edge science and life-saving therapies. So it's a double-edged sword. We're talking CGT, rare therapies, GLP-1s, for example. There are some game-changing drugs, life-saving drugs, but they're very expensive. And so when the MCOs meet annually to walk through the process of rate setting, we have quite a bit of attention paid to drugs because it's such an expensive part of the program. And these are some of the common reasons for a denial of a prior auth. I think for the clinical community out there, these probably rings a little true. Next slide, Craig. Wanted to level set here on this slide because this is really important. We've had a lot of discussions in different committee settings throughout the years on this topic in different forums. These are fundamentally payment disputes. This is not an issue of care delivery. This is about a dispute that occurs from a claim that originated from an emergency department. The MCOs must cover medically necessary emergency services 24/7 without prior auth. Prior auth obviously doesn't work in an emergency context, and EMTALA governs a lot of what we do in that space. MCOs have an obligation to ensure that the care is delivered in the most appropriate site and setting as part of medical necessity and utilization management. But again, we have to cover emergency services, but we do have an obligation to review whether those services met emergency criteria or medical necessity. Now, I consider these types of payment disputes to be items that the Maryland MCO Association and the Maryland Hospital Association can and should work together to try to resolve. And I'm committed to doing this work to create greater uniformity, both for the payers and systems and the provider and the providers, other providers as well. And I'm looking forward to working with them in the interim to try to see what work can be done to create some uniformity, both on our end and on their end. Next slide, Craig. So outside of medical necessity, claims are denied largely for administrative reasons, and this is just a sample list. It's oftentimes, each case is different, each member is different, and the circumstances are different, but administrative claim denials far outstrip other categories of denials. And I don't have the latest and greatest data, but I wanted to share this slide. I think it's an important level setter. Next slide. So some recommendations for next steps. I definitely think that continuing to work with the hospital systems through MHA and other provider organizations to create uniformity is a really important step. And Patrick and I have already made some steps in that direction. we have on this slide, and I think Dr. Dixon had it on her slide, the reports around appeals, grievances, and denials. One of the components on this recommendation is to ensure that the entire system is focused on cost savings. We have an obligation to think about affordability as MCOs, but I think all of our organizations are aware of what's going on fiscally with the state, and we want to just continue to promote cost savings across all sectors. One thing I wanted to hit on too is a lot of conversation about AI usage in carriers and MCOs, and what is and is not being used. There are use cases for AI in all sectors of the economy, and administrative simplification, care management, outreach, all of those tools can exist and do exist. But again, we're not allowed to use artificial intelligence decision-making use case tools for claims determinations or any determinations around medical necessity. One of the things we think might be helpful is to understand what kind of additional technology, revenue enhancement, or AI tools are being used by systems or providers in such a way that could exacerbate these challenges. But there's no rush. This is a changing environment. If you turn on the news, AI is different every single day in terms of the developments. So that's, Jai, I don't know if you had anything else to add to this last.
Well, just I can't put too fine a point on it, which is the standardization of the definition of reporting of adverse decisions is critical. We need to figure that out, and I think you captured everything else. Thanks.
Thanks, Jai. Next slide. And this is just my contact information. Most of you know where to find me. I have a teenage daughter, so texting me is the easiest way to reach me if you need to reach me. Happy to try to answer your questions. I don't know everything, but I know the people that do. So ask away. Chair Vile, you're muted.
Okay, thank you. My headset has gone on and out like 4 times during this presentation today, so I don't know what's going on, but if there's a technology problem, I'll have it. Thank you for your presentation, Mr. Zinn and Dr. Jai, and we have a question from Heather Little.
Hi, so on your slide for emergency department claims, you referenced that you want to ensure that the care is delivered in the most appropriate site and setting for what the condition of the patient is. And we don't disagree. University of Maryland Medical System, it is our job to take care of that patient that walks through the doors. And so my question is what kind of education are you doing to your patient population when you feel that they're using the ED incorrectly? So making sure that they understand that you feel like they should have went to a doctor's office instead. I don't feel like that's something that the hospital should be educating the patient on. That really should be coming from you, since you're the one that's denying the care. My 2 cents.
Thanks, Heather.
Heather, that's a great question, Joe. If I can
by all means
try a little bit on this one. Controlling ER utilization is an essential function of the managed care organizations. And some of the things that we do is we review ER utilization to identify the high ER utilizers, and then we'll provide direct outreach to those folks in case management services, because oftentimes there's behavioral health issues that are going on here. And our goal with that is to reduce that utilization and direct it to the proper place of care, which is oftentimes the primary care program. Primary care providers, which is why we're excited about the AHEAD model and what we're trying to accomplish there. We also get reports from some of our partners within MDH, like Hilltop, about ER utilization, which is developed and coming out of CRISP. But we use all of that, again, to target our outreach and our response to those members that are high utilizers, so that we don't want you seeing a person who's in there for a hot meal any more than you want to do that. So we're trying to intercede in those matters as much as possible. We'll provide cell phones to the folks that are at risk here and utilizing the ER inappropriately. We'll provide transportation to get them to their primary care visits. And we also contract with urgent care centers to try and get folks to go to the urgent care if it is a cold or a sniffle that they're contending with.
Thanks, Jai.
Thank you.
Heather, I can't improve upon Jai's response. So thanks, Jai.
Thank you. Thank you for that question. Dr. Dixon?
Yeah, I think I have a question. It's not just for Jai and Joe or the MCOs, but I guess a question to the group overall, since we do have many different types of expertise here on the call and involved in the work group. When we look at those common reasons for denial, and I don't know if we can pull that slide back up, and I didn't write down the slide number, I'm sorry. But when we look for those common reasons for denial that's outside of medical necessity, where are the systems failures, and how do we correct those system errors so that we can just kind of wipe the slate clean on those reasons and resolve all of those issues because we made the system better?
It's a great question, Dr. Dixon. And I think the system has, it's iterative and it's been improving slowly. And work groups like this address problems that we get there incrementally, of course. I think you'll start to see improvements in administrative claims as more providers and more systems are more uniform. Uniformity is a two-way street. It's not just on the payer side, it's also on the system side. But I don't know if others have perspectives besides me.
Joe, and I did go back to the slide, Dr. Dixon, and one of the number one reasons for claims denials outside of medical necessity was the member not eligible in the date of service. And we saw that drive some of the data points that have already been presented during the period of unwinding after the public health emergency, when we had unprecedented numbers of Medicaid recipients lose eligibility, but we were still getting those bills. So on that given date of service, the person may not be eligible. So that's one of the areas where, unfortunately, with the advent of HR1, I don't think that's going to improve as we get into work requirements and 6-month eligibility checks. It's almost like the redetermination or public health unwinding is on steroids as we go into 2027. So unfortunately, I think that will drive it. But it is important to establish the distinction between those sorts of denials versus adverse decisions. And that's why I really want to get that sorted out in terms of how we're defining that as a work group. Some of the other reasons for denial that we had on that slide: duplicate claim, service not authorized, or requested service is not a covered benefit. Those things, again, part of our role as stewards of the resources that we're entrusted to handle is to make sure that those rules are applied.
Thank you, Jai. Dr. York?
Yes, thank you. In the course of listening to all this, there was one particular comment about education of the public. A huge amount of money is spent by big pharma on all these very expensive drugs, and it's become such a prevalent thing, especially on the evening news, that even Saturday Night Live recently had a skit that mocked it. It's pretty funny. Is there a way, perhaps through public service announcements, to educate the public better about where to get your low back pain or a cold, to encourage them, go to an urgent care center, go to well, in Luminous, we have it's called a Today Clinic for orthopedic problems or for primary care type problems. Obviously, you don't want to scare people with chest pain away from going to the ER. It might be anxiety, or it might really be a heart attack occurring. This has been used in suicide prevention and with mental health, and the Ravens were involved in that with call the suicide line if you have dark thoughts. Is there possibly a role for doing that to help in some common things where it's very expensive to guide the public into areas where care can be achieved at a lower cost? So just throwing that out there.
Yeah, Dr. York, I don't know the answer to that. It's an interesting idea. I think the challenge in the pharmacy space is it's very fragmented and driven. It's individually driven, of course, by the course of treatment that a person might need for whatever condition they have. And so I think that if you were able to do a public campaign around cost of prescription drugs, it might have to be laser focused around a certain class of drugs or a specific disease state that's a public health initiative or something. It's not necessarily an area I know that much about in terms of messaging prescription drug behavior to the public. But it's an important problem because on one hand, these drugs are super expensive. On the other hand, they're life-saving therapies. And so we have to try to balance it out. There are mechanisms in place to try to mitigate some of those costs. I know that Andy York and the team at the Prescription Drug Affordability Board are doing some work, and there's rising awareness around the cost of these drugs. But I don't know that me or anyone on this call has a silver bullet. It's definitely a challenge.
Might not have a silver bullet, but this dialogue is important, Dr. York, and I
Yeah.
appreciate your comments greatly. I mean, we see these things on the nightly news, to your point. They have the catchy jingles, Sky Rizzy, and all of that, but I don't think the consumer actually knows that's going to cost $40,000 a month. So to your point, there needs to be education, and we are collaborating with the department in terms of education. We've just kicked off our campaign related to HR1 to try and educate the public about the redetermination that they'll have to do with the 6-month eligibility checks and coming work requirements. So I think there's a model that we could probably leverage at some point. So thank you for that question.
Yeah, it's a good question. Sure, Vital, you're muted again. I'm sorry.
Thank you. We have another question from Dr. Orafo. Maybe he's muted. Unmute, doctor. I don't know. His hand is raised, but there he goes.
Can you hear me now?
Yes, thank you.
So I work for a federally qualified health center, and just going back to access, right? So these are not necessarily denials. So in terms of the like specifically talking about hepatitis C medications now, just to be specific. So these medications, as we're talking about cost, right? They're expensive. They need to be closely monitored for the patients to be successful with the therapy. And majority of the times when we do fill these prescriptions, we're told to send those prescriptions to specialty pharmacies. Now, most of these specialty pharmacies are not local. So there's an access, it becomes a barrier. So we went through the accreditation so that our patients, again, we're dealing, we're a safety net healthcare provider. Some of our patients are homeless. We've tested they're positive for hepatitis C. I know there's the public health push to get cure and to get cure for hepatitis C. And now we process those prescriptions where we are accredited. Patients can have access to those medications right on site at our pharmacies. But we're being told, and again, majority of our patients are either beneficiaries for fee-for-service Medicaid or for the MCOs. And particularly with the MCOs, we're being told that they need to go to another pharmacy out of state usually. So again, to me, it doesn't make sense if patients can have access to these medications right on site with us. Why do they have to go why do they have to utilize out of state pharmacies?
So doctor, that's an excellent question. And I do believe that this is a policy clarification matter at the state of Maryland. And Dr. Dixon, I would ask that maybe you all take this back. I know that there was a survey earlier this year that you all conducted about this very issue. And I do think it's something that we need to rectify. These medications are critically important, and the cost has gone down in the past 5 years considerably since the advent of these therapies that offer a cure. And there's not many things that we can actually cure. So it's essential that the Medicaid population, which is a vulnerable population, get access to these life-saving medications. It saves money for the system over time, and that we won't have liver transplants for these folks and they won't die. So we support you and we support the department in clarifying its policy on this, but there should not be, from my perspective, a restriction to this medication, not in that way.
Thank you very much.
Can I just add to that? There will, if they haven't already been released, there are some changes to our Hep C medication policy. So be on the lookout for that. And if you're not able to resolve the situation, if that doesn't resolve the situation, I encourage you to reach out to me. Is your email on the guest list, we can connect offline.
Most definitely. Thank you. Will do.
Thank you. So I don't see any other questions. I thank you all for your presentations today. I think there's a lot for us to discuss further, and we'll make some additional recommendations, but they were great presentations and we really appreciate it. Typically, we'd like to have time for public comments at the end, but it is now past 3 o'clock, so we will not have public comments. If folks want to address a comment, they can send an email in to riley.williams@maryland.gov, and we can answer those questions directly, but we're out of time today. I see something in the chat. No, Raleigh put his email in the chat, so additional questions to that email, riley.williams@maryland.gov. So if there are no other questions or comments, we're going to end this meeting today, and we'll look forward to seeing everyone at the next meeting and continue our work together. Thank you.